Good afternoon, and thank you for making it to this presentation. What I thought I would do today is to give you a broad overview or a bird's eye view of some of the tremendous progress we have made in cancer in the last year or two. The first half of the conversation would focus on the progress. The second half will focus on The second half will focus on the challenges that we have in cancer care. This is just a disclosure statement that I have nothing to disclose. So to begin with, this is the top 5 advances in oncology over the last 50 odd years. This was a survey of a society called the American Society of Clinical Oncology oncologists. And this is the order in which they ranked the advances so far. And what you'll hear today is another major advance in cancer care. So chemotherapy cures Hodgkin's lymphoma, vaccine approved for the prevention of cervical cancer. The targeted treatment and the rare leukemia is chronic myeloid leukemia, and the target is tyrosine kinase, and the inhibitor is imatinib. In 1977, Larry Einhorn's group was able to cure testicular cancer with a cisplatinum-based therapy. And then the powerful anti-nausea drugs that alleviate some of the most important side effects of treatment was introduced in 1991. Ondansetron is the drug. So if you look at the distribution of common cancers across the board in the United States, you can see breast, lung, and bronchus occupy a significant percentage of the incidence of cancer, and the others are all outlined there. There's a large category of others which is consistent across many years. These are multiple different tumors all put together, which constitute a percentage of the total distribution. So if you look at mortality, about 500,000 Americans died of cancer in the United States in 2015. The mortality rates for bladder, brain cancer, and melanoma have remained very steady. But there is a trend for an increase in the mortality rate for pancreatic and liver cancer, both in men and women. And importantly, the mortality rates varied by race and ethnicity, and hence the concept of cancer health disparities. For the first time in 2015, breast cancer incidence among African Americans was higher than other racial groups, which is an important observation. So if you look at the US mortality rates in the males, you can see that lung cancer peaked several years ago in the early 2000s, and then it has started trending down. And pancreas and liver cancer slowly edging its way up. There was an increase in prostate cancer in the world of what we call PSA-itis, the phenomenon of checking PSA on every patient. And since then, after the decline in our fascination with checking PSA, it has started to trend downwards. This is the mortality figures in females, which almost parallels the mortality figure in males, except for breast cancer, of course, and the liver and pancreatic cancer continues to show an upward trend. So if you look at the pillars of cancer care, for several years from ancient times, surgery was the only treatment modality that was available. And then in the early 1900s or late 19th century, radiotherapy was introduced. In the 1940s, the first chemotherapy was introduced using nitrogen mustard. In the 1990s came the onset of what we call precision therapy or tailored therapy, where we were able to target certain aberrations in the cancer pathway and find drugs that worked against it. And the important example those days was chronic myeloid leukemia, where the first targeted therapy was used. Beginning in the 1990s, we had immunotherapy come through. And immunotherapy is one of the most important advances in cancer care currently. And I will show you several slides to explain that. So before we get into immunotherapy, I need to outline to you what is precision medicine or precision oncology. Precision oncology or genomics-driven cancer care is feasible because of the following factors. Cancer is a genomic disease, and most cancers harbor mutated oncogenes and tumor suppressors. Molecular pathways involved in tumor survival and progression are enacted by genetic alterations. And much of the cancers have already been characterized at the genomic level, and genomic technologies have so advanced now that we can characterize the gene profile of several of these tumors. And we have several anti-cancer agents that target these pathways. So if you talk of precision medicine, oncology is at the forefront of this field. So this is an illustration of what precision medicine involves. So you have the tissue that needs to be accessed by some form of biopsy procedure, either interventional radiology or surgery, and then is subjected to the gene analysis. And in the gene analysis, what is categorized is what is actionable, which means you have FDA-approved drugs that in principle should work against the mutated target or the druggable target. Then those that don't have drugs in standard care, you can put through clinical trials. Some of the gene information is of prognostic value, and then there are, of course, variants whose significance would be unknown at this time. The genomic alterations affecting oncology is well described. For example, if you look at lung cancer, between adenocarcinoma and squamous cell carcinoma, the signaling pathways that are actionable vary. You can see across the board different tumors have different predominant mutated pathways, and hence the importance of having to profile each and every tumor before you can develop drugs targeted against mutations. And there are several pathways that are potentially druggable, and here is the cartoon which tells us all the possible pathways that are currently being tested with drugs. This is a cartoon from the Journal of Clinical Oncology, which shows the pathway that is required in precision medicine, where you have to first take the biopsy, analyze it, iterate it, analyze the data, present it to the clinical team. Present it to the clinical team, and then treat. If the patient gets drug resistance, then go back and re-biopsy, and then subject it to analysis before you decide which drug is available. And this is now practiced in certain centers at the clinical trial level to find suitable clinical trials. The problem that, as you may readily see, is it requires several biopsies. But this may be overcome in the future with the availability of liquid biopsy, where you can use blood samples to be able to analyze DNA that are secreted into the system from tumors. If that comes to be a standard, then this pathway would be far simplified. Precision medicine took a big boost after the State of the Union address in 2015. If you remember, President Obama talked about a patient with cystic fibrosis who was in medical school. He was 27 years, and they found a particular mutation that was druggable, and he was able to live that long and go to medical school. There has been a big funding commitment to the process of precision medicine initiative, and it is considered possibly an important strategy to improve patient outcomes. Some of you may be familiar with this. This is a large initiative. It's called the Precision Medicine Initiative Cohort Program, where about 1 million subjects with $55 million in funding will be enrolled. And recently, the centers have been approved for this large initiative, where patients or subjects who are willing to participate will be given a questionnaire, biospecimens will be taken, and they will be given permission to access their medical records, and all aspects of this patient's or the subject's lifestyle, genes will be analyzed. And the following centers have been approved. There are several network hospitals, but importantly, the biobank goes to the Mayo Clinic at Rochester, and the Data and Research Support Center would be Vanderbilt in Nashville. The most important advance of the year, both at the society level, newspapers, news releases, patient stories, everything, is cancer immunotherapy. It's considered the most important advance in oncology. Basically, how do I summarize cancer immunotherapy in one line? Well, it's a method to release the brakes that are in play in malignancy, and I will explain to you what that means in a minute. So here's the man. His name is James Allison. He was at Sloan Kettering and is currently at MD Anderson. He is called the T-cell mechanic. What he did is outlined in 4 sentences. In 1980, he characterized the T-cell receptor. In 1992, he found the co-stimulatory molecule for T-cell called CD28. In 1995, he discovered the T-cell brake called CTLA4. And the antibodies are now being developed against that brake, which is what we use in therapy. So the major thought here was for many years that you need to stimulate the T-cell to do something good against cancer. Here's a man who said, no, it's not the stimulation that's important, it's to release the brake. And releasing the brake was achieved through the generation of antibodies. In 2015, he got the Lasker-DeBakey Award. My analysis is he's a potential Nobel laureate in the future. MD Anderson recruited him a couple of years ago, and he heads the immunology research division of Houston. So here's a diagrammatic representation of what happens. So basically what happens is the tumor cell blinds the tumor cell blinds the T cell. How does it blind the T cell? It blinds the T cell by blocking the TCR signaling pathway. So the blue is the tumor cell, and the T cell is suppressed. Is the suppressed T cell, the yellow one. The question is, how do you activate the yellow cell? So you activate the yellow cell by blocking this receptor. This is the PD-1 ligand, which the antibody will block and will prevent it from neutralizing this one, PD-1. So PD-1 and PD ligand are separated by the antibody. And that's essentially the principle behind all the new antibodies that are now being used. The first one being ipilimumab. And now we have several more antibodies. So if you look at melanoma, some of you may have heard the success story of Jimmy Carter's treatment, where one of these antibodies was used. Essentially, things were going very slowly for several years till about 2011, when 2 pathways were amenable to therapy. One was a mutation of the BRAF pathway, where if BRAF is mutated, you can use certain oral drugs. The first one was vemurafenib, and if not, patients could be treated with immunotherapy. And since then, I don't know if it's clear enough, but several drugs have been added on since then in the short period of 5 years, whereas there was such a slow progress for many, many years. Now we have oral drugs and the immunotherapy drugs. This is the only Kaplan-Meier curve I put in because this was the first Kaplan-Meier curve of how ipilimumab got approved for metastatic melanoma, and essentially it shows improvement in overall survival in the EP arm and progression-free survival in the EP arm compared to the vaccine arm. So these drugs are now called immune checkpoint inhibitors. The checkpoint is a term I think Allison coined. In fact, his music band is called Checkpoint. And the three targets in the checkpoint inhibition pathway are CTLA4, PD1, and PDL1. And the following, as of July, were the approved antibodies against this pathway. I've listed them there. They're tongue-twisting names. We call them IPI, PEM, NIV, and ATES. Since 2011, after the first immunotherapy approach was approved, FDA approved for melanoma, there's been several other disorders where FDA has approved the use of these drugs. Hodgkin's, lung cancer, kidney cancer, bladder cancer, and several combinations in melanoma. Some of them have been granted breakthrough designation and not yet FDA approved. Although John is here, he can update me in the last 2 months if some of them have been FDA approved. Head and neck cancer, I believe, has now been FDA approved. Hodgkin's lymphoma, Keytruda, colorectal cancer, and bladder cancer. And the list continues to grow. And it's very likely that there will be a larger number of tumors that are amenable to immunotherapy because the immunotherapy drug activates a normal cell, whereas malignancy across are due to several different mutations. So it's easier to equip the immune system to attack these malignant cells, and it was thought and still thought in large groups that the T cells once activated can attack all types of malignant cells. But what we are beginning to discover is there are certain subtle nuances to that attack, and I will explain that to you in a minute. So some of the further advances in our idea of immunotherapy are the following. The genetic abnormality of the malignant cell is tied to responses to PD-1 immunotherapy. I'll give you one example. Disorders with DNA mismatch repair, for example, Lynch syndrome, they have multiple mutations. And the theory is because of the multiple mutations, they have more antigens and are more amenable to immune therapy. And therefore, DNA mismatch repair disorders or malignancies may be more malleable to immunotherapy. It's also been seen that some combinations of immunotherapy may be superior to monotherapy. And on the other hand, there are ways to find out if one therapy would be good by looking at expression parameters. For example, higher PD-1 expression, the target for the immunotherapy, certain of the antibodies, there could be more response to single agent with less toxicity if there was higher PD-1 expression. So this field will continue to change and evolve over time, but we are living in an exciting field of new therapy. The other two immunotherapy approaches that are important are T-cell therapy and chimeric antigen receptor T-cell therapy or CAR-T therapy. The concept for T-cell therapy is the antibody is given on the top. It's called blinatumomab. This is a monoclonal antibody that is not directed just against B cell or T cell, but is directed against both B cell and T cell. So it goes and attaches itself or brings the T cell in contact with the B cell and is able to destroy the malignant B cell. Unlike the previous antibodies, which were purely against the B cell, this could bring the T cell to the B cell, tell the T cell, kill the B cell. And this has been successfully used in relapsed Philadelphia chromosome positive ALL. 1/3 of patients in relapsed ALL went into complete or durable remission following this approach. So that's one method. The other new method is, some of you may have heard about this, it's called the CAR T cell therapy. CAR stands for chimeric antigen receptor T cell therapy, where you take the patient's T cells, engineer them to recognize certain antigenic cells, antigen expressing cells, and reintroduce it into the patient, and the T cell now goes and is being programmed to go and destroy the B cell. And this has been successfully done in relapsed ALL and relapsed DLBCL, which is a diffuse large B-cell lymphoma. And I believe more trials and more data is around the corner. So these are novel therapies which are largely used currently in hematological malignancies. The third approach is cancer vaccine. This has been something that's been floating around for several years, but had not met with much success. Unlike preventive vaccines, these vaccines work differently. Preventive vaccines prevent something happening. Cancer vaccines target target certain antigens in tumors. For example, in glioblastoma, there is a particular mutation, a mutation called EGFR-V8. And you create a vaccine that targets that antigen, and about 25% of glioblastoma will respond, and successfully done in a trial, the median survival being better in the vaccine group versus the one with the angiogenesis inhibitor arm. And this approach is now being explored in a variety of cancers as outlined above. So moving on to the other advances in cancer prevention, the one that is important is the human papillomavirus related malignancies. And I have outlined to you some of the types of malignancy that are HPV related, and you can see the high percentage of them that are HPV related. And the advance in cancer prevention is the introduction of this particular vaccine. This was the first one, the second one, and this is the third one. This, I believe, was introduced 2014. And as you can see from here, the HPV coverage spectrum has increased from just 2, now we have HPV of all these serotypes covered by this vaccination. So it's better coverage against more carcinogenic HPV strains. But as you would see later in the challenges in cancer care, there is a problem in the United States with HPV vaccination. The other important is a progress in cancer concepts. And one of the new concepts in cancer prevention is, after the advent of the immunotherapy success, has been the phrase cancer immunoprevention. And what it underlies is, we know that we can attempt to prevent cancer at an earlier stage with non-chemotherapy drugs, and there are examples of it. For example, aspirin in colon cancer or tamoxifen in breast cancer. But what cancer immunoprevention attempts to find and progress on is, can we use immunotherapeutic approaches to prevent cancer at an early stage? Which means we have to understand the antigenic profile of early cancer. So that's the challenge. And here's a conceptual diagram of what we're referring to. You can see carcinogenesis starts from a normal cell to pre-cancer till it progresses. And there is an immune mechanism which can prevent even if it attempts to go this way to bring it back to normalcy, or a pathway that can eliminate it, as you saw in earlier slides. So the idea would be to find out how we can capitalize and be able to intervene or use immunotherapy in early cancer where this reversal doesn't happen and it progresses. Exciting concept waiting to be proven. And this roughly tells you the pros and cons of this approach. We believe that immunotherapy could be associated with lower toxicity. And the important thing is the immune system has long-term memory. So if you could manipulate the immune system favoring elimination of early cancer cells, maybe it will sustain for a longer period of time. And we can combine it with other drugs. Again, not to fail to emphasize, these are early concepts waiting to be proven. So there has been some advances in the drug approval process. Traditionally, the FDA took a long time to approve oncology drugs. But now the FDA has got certain tracks which help us get drugs approved quickly. And they are called the expedited review strategies. And there are the following terms called accelerated review, fast track, breakthrough designation, and priority review, which has helped us immensely to get drugs quickly approved and be available for the patient and the consumer. I'm not going to spend time on the definitions, but each of these concepts, there has been examples of recently drugs in hematology oncology that has gotten approved under one designation or the other. The other major advance in therapeutics, some of you may have heard, is the concept of biosimilar. In a cost-conscious world, biosimilar offers a lot of excitement. What's a biosimilar? A biosimilar product is a biological product that is approved based on a showing that it is highly similar to an FDA-approved biological product. And the hope is its efficacy will be as good as the original product and it will be cheaper. The first biosimilar was approved in the United States in the year 2015, and it's called filgrastim-SNDS. SNDS stands for Sandoz. There's been more debate about how best to name these biosimilars, but for now it's called filgrastim-SNDS. And it's biosimilar to the growth factor called filgrastim. And it's the best I can see is it's offered at a 15% discount, but we have to wait to see if it will reduce, if in general, the biosimilar product will reduce the cost of drugs across the board. We still don't have definite proof, but that's the hope. And there are more biosimilars being studied as we speak. Some of you may have heard me talk about the hallmarks of cancer. The hallmarks of cancer was a concept that was released by a very famous duo cancer researchers called Doug Hanahan and Robert Weinberg. There were 6 hallmarks when the paper was originally published in 2000, and it was one of the most highly reviewed, cited papers. More than 20,000 times they accessed it. The Weinberg and Hanahan has since revised the hallmarks to include 4 more. And these hallmarks are important in influencing the properties of cancer, including how it grows and how it invades. And I'm showing this slide because now we have a pipeline of drugs that target these hallmarks. And the pipeline, as I had written here, is deep and in drug and in development. So what are those hallmarks? The hallmarks are outlined in the inner circle. For example, Here, sustaining proliferative signaling is the hallmark of cancer. And what is the way to target that is EGFR inhibitors. For example, enhancing or enabling replicative immortality is one hallmark. And the way to target that is telomerase inhibitors, and so on and so forth. So this is an important concept that helps drug development based upon science of individual characteristics of tumors that dictate proliferation and invasion. Moving on to progress in cancer coverage, cancer insurance coverage. This is important. Some of you may wonder why we are moving on to insurance and healthcare, but these are practical, important parts of any healthcare delivery system. The expanded cancer coverage of the Affordable Care Act prohibits coverage exclusions. It eliminates lifetime caps. It expands the routine coverage for routine health care, including hospice care and palliative medicine. It covers routine costs of clinical trials. And it also covers screening, wellness, and preventive care. And children with cancer, when they survive into early adulthood, can be on parents' insurance till they are 26 years. So these are the main important tenets of the Affordable Care Act. So those are, in summary, what I think were key advances in cancer care. Now I move on to what are the challenges. Remember, the first thing I showed you was progress in precision oncology. So what are the challenges in precision oncology? I've outlined to you some of them, some we discussed earlier. The most important and most profound challenge I find is the first one, intra-tumor heterogeneity. There was a paper a couple of years ago from the Vogelstein group that characterized tumor genotype, gene profiles. And what they found was the tumor varies in genetic characteristics within the primary tumor. And if you look at metastasis, for example, colon cancer, gone into the liver, and there are 10 mets in the liver, each one of them had its own genetic characteristics. And within a met, there were differences. So how do you develop targets when the tumor shows such wide heterogeneity? It's a problem. Serial biopsies, as I had outlined to you all earlier, is a problem. There are still technical challenges and availability of treatments. There are ethical issues with incidentally finding germline mutation. How do you discuss that with the family? Cost is a huge thing. To set up the platforms to do the genetic tests, and the drugs will cost a lot. And how do you design clinical trials to fulfill the statistical need to establish advantage? That's a problem. So these will have to be ironed out before precision oncology comes to stay. What are the challenges in cancer prevention? Well, cancer prevention was a concept that was suggested years ago, and in particular the word chemoprevention, some of you may have heard, was basically using non-chemotherapy drugs to intervene at an early stage, as seen here, for example. At the pre-cancer stage, before it progresses, you want to do something here to prevent it from progressing. And the methods were surgically remove it or use drugs to inhibit its growth. Screening has come to stay. Screening, for example, colonoscopy and polyp removal, that's a well-established method. Cervical pap smear is a well-established method. The problem where we have run into is therapeutics. There are few clinical trials that have shown that certain drugs can prevent cancer from happening, chemoprevention trials. And the good examples are tamoxifen and raloxifene for breast cancer, And recently, the USPTF approved aspirin for certain situations in colon cancer. But the acceptance of this among primary care providers and subjects who could benefit from that is not very good. There is fear of toxicity, and there are certain ill-defined fears. Then there has been the powerful impact of some trials being very negative. In fact, it showed an increased incidence of cancer. And that has put off many people to even consider this approach. So I think the field will have to move forward into a genomics-driven cancer prevention era or immunoprevention, which may be less toxic and more long-lasting, we hope. The other challenge is this phenomenon that we have seen. Here is a graph showing the rate of utilization of HPV vaccination in several countries in Africa, Australia, United Kingdom, and United States. And you can see the acceptance rate in United States hovers around less than 40%, a little more than 30%, compared to Rwanda or Botswana, where it is close to 90%. This needs to be worked upon. We have to make every attempt to see if we can expand the utilization of this powerful method to prevent a series of malignancies in the population. Moving on to healthcare delivery problems and challenges. There's going to be increased demand for cancer care. I will outline to that in subsequent slides. We have to deal with health disparities. We have to now wrestle with new criteria on cancer screening. The complexity of cancer care. How do you deal with the more and more complex multidisciplinary cancer care that is now standard? Access to cancer care. Affordability. How do you address the workforce need given the rising incidence of patients with cancer? How do you strategize for delivering high quality, high value cancer care in the health reform environment? These are all challenges that need to be addressed. So here is an approximate figure of projected figure for the incidence and mortality of cancer in the United States. You can see the incidence goes from 1.7 million to 2.3 million by 2030. And the mortality is almost doubled. And the rising aging population, 46 million to 61.6 million, is another challenge because with that comes increasing incidence of cancer. For all said and done, the biggest risk factor for cancer is age. Cancer health disparities in these two slides I will summarize. These are the problems with disparities. Access to health care, racial and minority groups, there are disparities. Low socioeconomic status causes disparities. Geographic inaccessible areas to health care cause disparities. Elderly health literacy, certain genetics in certain racial populations, and then the unknown environmental cancer risk. They're all responsible for several examples of healthcare disparities. I'm not going to go into the details of the slide, but if you focus here, the top example, 27%, the overall cancer death rate in African American population with prostate cancer compared to white men. And the death rate in women is 14% higher, and so on and so forth. So it's an example of racial and ethnic disparities, which we have to wrestle with and solve. So cancer screening has gone through a lot of ups and downs. And the general rule now is avoidance of over-screening or under-screening. And we have examples of over-screening, the PSA phenomenon. There has been clear benefits in certain age groups for the following malignancies: breast, cervix, colorectal, and recently lung. The findings in prostate, bladder, skin, and oral are inconclusive. If you look at prostate cancer recommendation, it's all over the place. There's no firm recommendation. The mammographic guidelines after several years has been revised to represent as being useful in later ages and also less frequently than advertised or recommended before. And this is the consensus among cancer screening recommendation, and you can see there is, if you look at the last one, the prostate cancer, there is little consensus among all these societies as to when and how to screen for prostate cancer. Moving on to the last phase of this is some of the gaps in the healthcare coverage, which we all in practice encounter quite often. The Affordable Care Act has helped millions gain access to insurance, but then millions remain without insurance, and the numbers are given there. 35 million non-elderly are uninsured, and 31 million are underinsured. And this is partly because of incomplete Medicaid expansion and coverage gaps in the exchange programs, the ACA exchange mechanism or marketplace coverage. These have caused gaps in healthcare coverage. The ACA first introduced private insurers to cover costs for routine costs in clinical trials. The coverage mandate is now in statute, but no federal regulation has been released to guide the implementation of this law, of this mandate. And Medicaid was excluded from the mandate, and by default it excludes the poor and minority. And phase 1 clinical trials are not included in this coverage. So these are challenges that need to be ironed out. The term now we use is financial toxicity. There are challenges of financial toxicity because of rising cost of cancer care and drug costs. Cancer costs are rising more rapidly than other medical sectors, and it's projected to be $173 billion by 2020. And the reasons are outlined here. Development of new technologies and treatments, consolidation of oncology practices into hospital-based practices has shot up cost, rising drug prices. Here is a figure from ASCO, American Society of Clinical Oncology, data culled from the Memorial Sloan Kettering. And what I need you to focus is essentially where the curve is right now. So it's about 10,000, somewhere between 10 and 12,000 is the average median monthly price of new drugs that are available for cancer care today in the United States. And there are several attempts being made to bring this down, which is a whole different separate topic on its own. Oncologists have gotten together. There is pressure for the government to move on this, but no clear answer is still forthcoming. And patients continue to have high co-pays, higher deductibles to meet the cost of these drugs. The other challenge is an oncology practice workforce. On the left is the increase in oncologists, or the total number of oncologists that we have, taken from two data sources. And basically the growth in oncology, hematology has been 1.1%. And who are engaged in, and those engaged in patient care outlined here. The problems with the workforce are it's an aging workforce. The median age is 51 years. And the geographic distribution of these hematologists, oncologists remains very uneven, with less representation in rural and remote areas. So there has been attempts to meet this workforce by supplementing with advanced practice nurses, physician assistants, and other personnel who could help with the multidisciplinary care delivery of cancer. So going on to challenges, what are the challenges in cancer care delivery? I won't spend too much time on this, but if you have questions, I will be happy to answer. The new healthcare reform and the emphasis on patient-centered care models is going to create a lot of pressure for oncology practices to meet that need. Some of you may have heard about the payment reform from Medicare called MACRA, which just released its report last week. The alternative payment models and how oncologists' practices are going to be reimbursed and the quality measures that have to be met are going to be challenging. Because in the new model, it's value over volume. So it has to be valued, there has to be performance measures met, and there are a whole slew of requirements that have to be met before you get your payments in order. So some of our, in oncology, for example, the NCCN, this is a comprehensive network of more than 20 NCI-designated cancer centers that release guidelines of standards of care, have put what, beyond just standard of care and category 1, 2, 3 recommendation, they have now put a category called evidence block. Basically, it's a color-coded method which says, although this is category 1, this is the evidence for the factors in cost and toxicity apart from just advantage in outcome. So this is, I'm sure, will come to be in several fields. Several quality measures are being implemented through oncology pathways that have to be met. And ultimately, there is something called EHR interoperability. One of the mandates of the Affordable Care Act is that the electronic records should not only be in place in healthcare systems, but should be able to communicate with other healthcare systems and across the board so that the data is available for analysis. So this is a huge challenge, and everyone's wrestling with how we're going to do this because it's cost heavy upfront. Now, just switching to the last part of it. So in 2015, President Obama introduced the idea of precision medicine. In 2016 State of the Union, he introduced the initiative called the Cancer Moonshot program. And the idea was to accelerate cancer research, to increase the availability of cancer treatment to more people in the United States, and to improve the ability to prevent cancer and early detection. The final recommendations were presented to the White House on October 17th, just last week. So this is the promise of the Cancer Moonshot Initiative. And there are several subcategories to each of the 5 important principles. Catalyze new scientific breakthroughs. Unleash the power of big data, that is whole genome analysis, profiling, data platforms that are going to churn out tons of data, and everyone will be forced to analyze it, and that will require heavy investment, and they're going to help us, I hope. Accelerate bringing new therapies to patients, strengthen prevention and diagnosis, and improve patient access and care. I reviewed this last weekend. The principles have been released. The final document has been given to the White House. And as I was telling Dr. Stewart earlier on today, a week before Biden presented this to the president, IBM donated its Watson computer to the VA system so that 10,000 cancer patients in the VA population could be analyzed and data generated. So I close by saying that the progress in cancer will be met by collaborative research, collaborative work that involves all these institutes, patients, survivors, caregivers, family and friends, healthcare providers, government institutions, pharmaceuticals, regulators, policymakers, philanthropic organizations, and federal funding and payers. Thank you. The Cancer Moonshot Initiative budget has not been defined for those who would like to know that. I'm sure Bill Stone is here and he would like to know that. It's not yet been released. I believe it will come the early quarter of 2017.